Today we'll talk about adjustment disorder. Particularly, it is defined as the emergence of psychiatric or behavioral issues within about 3 to 6 months of an acute stressor that causes you to have a maladaptive set of emotions or behavior that in turn can result in a decrease in your functionality at work, relationships, sports, or other types of spheres. Generally, adjustment disorder can happen with a depressed mood, you can be anxious, you can have a mixture of those emotions. It can also be behavior dysregulated, that's when it's called adjustment disorder with disturbance of conduct. And can also have an amalgamation of both, which is called adjustment disorder with mixed disturbance of emotions and conduct. Generally, it happens when there is an acute stressor, for example, end of a romantic relationship, loss of a job, or having other financial constraints. It can also occur if you're having persistent stressors for extended periods of time and then an acute stressor happens. Generally, it can be diagnosed when you have an acute abrupt change in a person's life, which is a precipitating event of this set of emotions, such as anxiety or depression or disturbance of conduct, which is very acute in change. Generally, it is quite prevalent. It's far more common than compared to major depressive disorder. It's a very common diagnosis in healthcare settings. Around 15% of psychiatric emergency department visits are related to this, and it's pretty prevalent. Generally, it's a very short interval between the appearance of this symptomatology, and it is highly associated with at least a suicide attempt than compared to other disorders. Although we do not know the exact pathophysiology, it is likely linked with some neurochemical changes that happen in context of an acute stressor. In terms of evaluation, we have to be cognizant of delineating if it's an adjustment disorder versus if it's a depression issue, PTSD issue, or anxiety-related issues. And there are occasions where they can both overlap on top of each other. The risk factors do include issues like romantic relationship dissolution, female gender, having access to guns, having financial constraints. Now, there are different treatment modalities for the same. The non-pharmacological, which means no medication treatment, includes psychotherapy. It also helps in promoting better coping mechanisms and understanding your maladaptive responses, understanding stressors and how oneself responds to a stressor. Additionally, engaging the family and community resources is an important element to think about as well. Pharmacological treatment, on the other hand, which is treatment with medications, is something that you need to think if the symptoms are severe enough, if they are extended for long periods of time, and in that circumstance or others, you can think of possibly starting antidepressants as well. Something to be careful about is generally adolescents who have adjustment disorder can develop other major psychiatric illnesses like depression, PTSD, generalized anxiety, and they have to be monitored quite closely. Let's talk about a related topic of grief and bereavement. As for the definition, if you have a loss of a loved one, loss of a relationship, you will go through sadness, and that is common. It's acute grief, totally normal. It becomes complicated grief, which can be more pathological, if it's extending for greater than 12 months for adults and extended for greater than 6 months in children. There are different kinds of grief reactions, and they include numbness, separation distress, depression, and eventual recovery. The way to delineate between acute grief, which is normal, and compared to complicated grief later is to see that in acute grief, you have loneliness, you have crying, you have symptoms such as stomachache, disrupted sleep, disrupted appetite, persistent memories of the deceased, feeling drawn to events or items that were associated with those loved ones, social withdrawal, numbness, disbelief, shock. And they are congruent with the person's cultural beliefs, religious belief, or the developmental stage. The difference with complicated grief is that these grief symptoms that are there, they are prolonged and they're so intense that they disable you for extended periods of time. You can even have difficulty accepting that the person has passed away or they've actually left you. It can have distressing memories of the deceased. Hallucinations can also happen. You can have suicidal thoughts to desire to be with the deceased or separated individual. You can develop distrust of others, and eventually, even the grief, both acute and complicated, can be maladaptive. Grief, when it's acute and it's only short-lived, is understandable even by individuals that you're surrounded with, compared to complicated grief that extends so prolonged that even the individuals around you do not give you empathy or compassion for that, and eventually it becomes maladaptive to your functioning. Acute grief is very prevalent, and it's around 57% of individuals will have it who experience an acute stressor, compared to complicated grief, which extends for greater than around 12 months for adults and greater than 6 months for children, and that extends to around 2 to 5% of individuals. Some of the risk factors for grief are if you're an older age, greater than 60 years old, female gender, low socioeconomic status, non-Caucasian race, if you have an history of other comorbid diagnoses such as anxiety or depression, if you lose a spouse or a child, and losing of a child can really result in much more intense and lasting grief. It can also be around sudden or expected death of a loved one as well. Once again, you have to be careful in delineating its grief, particularly if it's acute grief versus chronic grief versus adjustment disorder versus depression or PTSD. However, regardless, they can all have these negative schemas that can be dealt with either by therapy and talking through it, CBT, which is also another kind of therapy, behavioral activation, outpatient monitoring by a psychiatrist. If all else fails, you can also start the patient alongside therapy with medication, or you can start medications after therapy. And some of the medications that are efficacious are antidepressants again. Once again, both the use of therapy, regardless of what kind of therapy you're using, interpersonal, CBT, psychodynamic, or motivational versus medication, they both are trying to tackle the negative schema that is developed and to make the brain more adaptive and improve the functionality to be more adaptive in society as well. Thank you for listening. Please look down at the disclaimers and any other information that you require. Thank you very much.